I'm going to talk a little bit right now about some newer work that I've been doing in my lab related to adapting the diagnostic process to telehealth approaches. And one of the great setups that I think that we just heard in the previous presentation is that there are still a lot of disparities in access to diagnostic services, or actually to services, period, but I'll talk about diagnostic services today. So there are large regions of the United States, for example, that have almost no diagnosticians. They don't have medical centers that have autism expertise. A lot of this is in rural communities and medically underserved communities. There's also disparities in access across the socioeconomic strata. So families that have higher incomes or higher educational levels of the parents, they have higher rates of autism diagnosis. And we don't think that's because there's any differences across the SES strata. We think it's because there's better access to diagnostic services among those groups. There's also disparities in the timing of diagnosis. So children of color largely get diagnosed later than other children. And finally, basically all of this got a lot worse during the pandemic. So during the mandatory shutdown, when clinics were closed, we all had to think about ways to adapt the things we do with families that we could keep services going. So our group started collaborating with a group at Vanderbilt University during the pandemic to try to understand whether using telehealth approaches to diagnosis and developing counterparts to sort of the components of the diagnostic process was equivalent, and whether we were getting accurate diagnoses, whether the way we measure things was equivalent, and whether families were getting access to services just as well. So these are only two of the components of a diagnostic evaluation. There really are a bunch more, but the most important ones are observation of a child's behavior in the areas that are relevant to autism diagnosis, so their social engagement, their ways of communicating their needs and their interests, repetitive behaviors, things like that. And then we also look at their overall general development, which Dr. Zwegenbaum also talked about a bit earlier. So their motor functioning, their speech development, their adaptive daily living skills, and their cognitive development. And so in in-person evaluations, we use the ADOS as the gold standard for observing autism-relevant behaviors. And the measure that we've been interrogating in our lab and trying to understand more about to use for telehealth counterpart is called the Tele-ASD-PEDS, or also called the TAP, and this was developed at Vanderbilt. And then the counterpart to the Mullen, which is what we use for in-person evaluations of general development, or sometimes use the Bailey scales. Those are directly administered measures where examiners with a lot of expertise in testing will assess how well the child's doing in all these developmental areas, and there's really no counterpart for that where we can guide parents through doing those kinds of activities over telehealth. Instead, what we use are interviews where we just ask the parents about developmental milestone attainment and different areas of development. But what we need to know is how well do those map on. And so some of this was already being done prior to the pandemic, but during the pandemic, there was this very rapid rollout of all of these measures across the world, really. And the Vanderbilt team trained a lot of people in how to use the TAP, including our center here. And so we got a lot more data on it. In fact, there really was very little published about what the accuracy of telehealth was before then. So I contacted the folks at Vanderbilt because I was really interested in this area, and I said, like, hey, if you'd ever want to go in on a study together, why don't we see if we can measure, how accurate these telehealth assessments are? And Zach Warren's team took us up on it, and so we've been doing a study with them since 2021 that's funded by NIH. It's a registered clinical trial. And we're basically looking at how comparable the results are across telehealth and in-person, and then looking at time to service access to see if it delays families from getting intervention if they only have a telehealth evaluation. The study design is that we're going to see 360 toddlers, and so far we've seen about 200. And all of those families first have a telehealth visit, and then 2 weeks later they get randomized which half of the families then come for an in-person visit so that we can compare those two, and the other half of the families get a second telehealth visit so we can compare the reliability of the two telehealth approaches. We've learned a lot about how this works in homes over the last 3.5 years, and we found that using whatever the home context is, whatever materials are present in that family's home, whoever else is around, it all actually works fine. It's very flexible. So some families have setups where it's a really open floor plan and they're really worried about the child staying on camera, so we can conduct the assessment with the child in a high chair. Sometimes there are other family members, or actually very frequently other family members in the room or walking through talking while we're doing the assessment, and we get to see lots of cute animals, which is one of the best parts. Some families have tons of materials and ways to work with the child with lots of different educational things. Some families have fewer. All of this works just fine. We're really able to work, it's very flexible. We've seen about 200 children, and it's a pretty diverse sample. Over half of the children are children of color or children who their families are not primarily English speakers. But I wanted to point out another type of diversity, which is we have a lot of socioeconomic diversity in this sample. 2/3 of the sample have incomes that are below the median level in California, and that's really different than your average research sample, or at least every research sample I've ever had, where it's largely people who are of higher means who volunteer for research. So we have families with diversity of incomes and also with diversity of education, so less than half the families are college educated too. And then the things we've made the strongest push for is trying to get a lot of individuals from rural areas. You could see in this heat map here that, of course, we have a lot of families from around Sacramento, but we also have families who come from the Sierra Nevada region, from up along the Oregon border, from really rural towns in the Central Valley. And the average one-way driving distance, one way, for the individuals in the study is almost 90 miles, with an average one-way driving time of over an hour and a half. So essentially, this is the cost in time and gasoline, too, of having a telehealth visit for these families. So what are our results so far? First of all, we're able to make a diagnostic decision almost all the time based on just the telehealth visit alone, the first one, 92% of the time. Then they get randomized, and so for the half that come in for an in-person visit, 95% of the time we get the same diagnosis as we did on the telehealth visit. And then for the other half that get a second telehealth visit, 94% of the time they get the same diagnosis, so it's highly reliable. Then we also are looking at the correspondence between the parent interview of developmental milestones called the developmental profile and the in-person testing using the Mullen scales. And this shows a correlation of those two, of the overall score, and you can see it's quite high, and there's a lot of clustering along that central line there. But what we found that was, I think, the most important is that 90% of the children who met eligibility criteria for services based on the Mullen, based on direct testing, also met based on based on parent interview. So the parents were able to very accurately describe their children's difficulties, and very few children, 10%, wouldn't have met criteria if we had only interviewed their parents, so a small group. We asked the parents after the assessment about their satisfaction with the procedures, and you can see that there's a high rate of people saying the instructions were easy to follow, we understood what we were doing, we felt comfortable following directions, and we felt comfortable, this was important to us, getting feedback over telehealth, hearing that your child does or does not have autism. I'll let you read these on your own, but we also put some of the testimonials in here about the sort of open comments families give us, and the themes really are around convenience, not having to find childcare, parking, car seat issues, those kinds of things, but also, of course, and we're practically forgetting this now, which is nice, but exposure to the virus, and a lot of families were very concerned about that. So there were things that people did like about it. There were not many challenges with telehealth either, and this was something we were really interested in. Very few families, 7%, said that they had any broadband issues that made it difficult to conduct the assessment. And think about back to that heat map of the geography. This was a highly rural sample, but pretty much everyone was able to have enough Wi-Fi access, et cetera. And very few, almost nobody said, I didn't have the right materials or the right setting. None of the challenges that got reported, in fact, prevented us from completing a visit. And over 90% of the families said they would do another telehealth evaluation. So in conclusion, we think that there really are probably still opportunities beyond the pandemic to keep using telehealth. And I think that Lonnie did such a good job of talking about this earlier, but there are families notice challenges or difficulties a lot earlier than they can get in for diagnostic evaluation. Even pandemic aside, there are just a lot of access problems. So we're really hopeful that continuing to use telehealth sometimes and for some children will help people get quicker access, broader access in rural areas, reduce the time to diagnosis and to services, and help medically underserved communities. So I just want to quickly thank our funders, thank our collaborators at Vanderbilt who collected half that data, and then especially thank the families who participated in the study and my amazing team.
Thanks, everybody, for being here, and I'm happy to have the opportunity to talk to you a little bit about the work we've been doing in my lab focused on early detection across neurodevelopmental conditions, and in particular, across autism and ADHD. But the point has been made pretty well today, but that by the time these conditions are typically detected, they can already be difficult to treat or to intervene. And we see these commonalities across autism and ADHD that maybe we don't all know about, but that are interesting and lead us to be interested in understanding these conditions together. So for example, they co-occur at rates well above chance. We also see some evidence of overlapping genetic risk markers. We see evidence of shared heritability. So moms who have ADHD are not only more likely to have a child with ADHD, but also more likely to have a child with autism. We see elevated rates of autism in younger siblings of children with autism, but also in younger siblings of children with ADHD and vice versa. So we see some overlap there. And then we see some evidence of overlap in the phenotypes, especially associated phenotypes. So, some of the things that Dr. Zweigenbaum talked about, attentional differences, or differences in cognitive control or reward pathways and things like that. And so some of those areas of overlap have been very interesting to us in terms of thinking about whether there's this utility of looking at things transdiagnostically or across conditions, whether we can pinpoint some of those processes that may overlap across autism and ADHD and identify those, and then potentially improve early detection, improve early intervention by focusing on those areas of overlap rather than things that may be specific to one condition or another, with the idea of improving earlier detection and identifying the right times and the right domains to intervene earlier to kind of get a better bang for our buck across these conditions before we know which path the child is on. So the goals of the broader research in my lab have largely been focused on understanding early life factors that influence the development, expression, and impact of autism and ADHD. So as I mentioned, really focusing on identifying those early markers that indicate increased likelihood for these conditions early in life, and then thinking about how we can use that information to figure out what areas are overlapping, what areas are distinct, and then how can we utilize that information to think about differences in early detection and intervention approaches. So Dr. Zwangenbaum did a nice job talking through what these types of studies look like. So similar to what he mentioned, we have been using prospective familial likelihood designs in our lab, focusing on infants who have a low likelihood of developing autism or ADHD because they have only typically developing older siblings and no family history of autism or ADHD. Infants who have an older sibling with autism, and then infants who have an older sibling or a parent with ADHD, because autism and ADHD are both pretty heritable or highly heritable, just to kind of increase that variation in our sample. And again, this has been described, this approach, but where we recruit these infants early in life, 6 or 9 months of age, and then follow them at regular intervals. Currently until the age of 3, we hope to follow them longer, especially because we have this interest in ADHD, which is diagnosed later. But we collect lots of different data on the infants when they come into the lab at each time point and from the parents. And then at that final study visit, we make diagnostic determinations. Similarly, we'll diagnose autism earlier if it's appropriate, but we make those final determinations at age 3, whether the child has autism, whether they're showing elevated ADHD symptoms, so not a diagnosis, but early concerns for ADHD, what we call ADHD concerns, or neither. So I thought, based on kind of the theme of today, I would just kind of give a flavor of what this kind of work has looked like in our lab, and then talk a little bit about some newer directions very briefly. So first, just thinking about that transdiagnostic approach and what we might want to look at, we've looked at attentional differences and motor activity differences. The first study on your left was led by Dr. Bert Hatch, who was a former postdoc in the lab, and he looked at one aspect of a behavioral manifestation of attentional orienting, so whether the infant responds when their name is called. And so what he found in the kind of green color was that the infants who developed autism by the age of 3 were more likely to fail to respond to their name, starting at 12 months and then persistently, than the group that we call the comparison group, so the group that neither had autism nor ADHD concerns outcomes. But we also see that the group with an ADHD concerns outcome was also more likely to fail to respond to their name at 12 and 18 months than the comparison group, and then you can see they look just like the comparison group at 24 months. So this suggests that possibly this kind of attentional orienting piece could be a more general marker for autism and ADHD risk in infancy, and then becomes something that's more specific to autism by age 2, potentially. And then Dr. Rachel Reedsky, another former postdoc, looked at motor activity in these infants using little accelerometers. They're kind of like a Fitbit that the babies wore on their ankles when they came into the lab that measures their movement, their motor activity, objectively, to see, is there something about activity level? We're interested in ADHD, hyperactivity, and she actually found that that this didn't differentiate the group, the infants who went on to develop autism from those who went on to develop concerns for ADHD, which is a little bit surprising. So maybe somewhat of a shared precursor in these samples, starting at 18 months. So I think, we got such a nice overview about kind of the way things have been done in the autism field, and we're very behind in the ADHD field when it comes to early detection and early intervention. And so we've been very interested in thinking about how can we build off of what has been done in autism, those methods, and apply that to ADHD. And one of the things we've been thinking a lot about is how could we study early indicators of ADHD better and rely less on the familial likelihood approach and think more about infants who are maybe showing behavioral differences that indicate a likelihood for ADHD that might be more efficient. So we've been developing and are still very much in the process, an early screening measure that's very short, 30 yes or no questions that parents fill out, takes less than 5 minutes, And we've been administering this in a sample of infants who are at high or low familial likelihood for ADHD. But the idea initially is just whether we could develop a tool that could help us do a better job recruiting samples that can move us more quickly down that path of early detection research in ADHD. And maybe there could be some clinical utility in the future if we're lucky. So we have just very preliminary psychometrics on this measure, but it's still in the early stages. We're still collecting data, which is why you see the sample sizes go down with age, because kids are still coming in this study. But overall, this metric for those who are psychometrics enthusiasts is equivalent to Cronbach's alpha for binary variables. So pretty high values, which is a good thing, which is good in terms of thinking about internal consistency of this new measure. And then we were interested in validity, sort of to begin with, looking at whether the EASY scores correlate with other measures that measure, we think, somewhat similar domains. So temperament measures related to activity level or attentional orienting, inhibitory control. And what we can see is that in the convergent validity section, we do see that the EASY scores are significantly and moderately to strongly correlated with these temperament measures in the expected directions. So sometimes positive, sometimes negative, but those make sense. And equally, reassuring is that they are not correlated with things we don't think they should be correlated with, like nonverbal developmental level on the Mullen across ages. And finally, very preliminary, looking at predictive validity. So do these EASY scores at 6 through 18 months of age correlate with ADHD rating scale scores on the preschool version at age 2, which they do so far. So we're going to keep going with this and keep collecting it. We see some differences based on the familial risk groups on the total scores at age 2. But we have some kids who have been classified into an outcome group by age 2 or 3. And it's a small sample, but we see more striking differences there, which is good to see. So the infants who went on to have elevated preschool symptoms of ADHD they have higher EASY scores starting at 12 months of age compared to those who don't have that outcome. And then the last thing I'll just briefly mention is, again, trying to build on what's kind of the approach that's been taken in autism related to early intervention, thinking about what could we do here in the ADHD sphere. And so we, with colleagues, we've developed an early intervention that's sort of parent coaching based, telehealth administered, focused on building self-regulation skills in these infants who are either at familial risk for ADHD or showing early self-regulation difficulties. Self-regulation is something that's quite impacted in ADHD, so their attention regulation, inhibitory control, and even emotion regulation. So the idea here is that if we could provide these skills to parents at 12 or 18 months in these babies who are showing some challenges in this area, maybe that could shift the trajectory over time. So it's very small. It was a pilot, and we're still coding lots of videos. But I can just show the parent report measures, which seems so far like the parents feel like they've had a good experience. They've liked their coaches. They have confidence in their coaches, and they feel quite satisfied with the strategies that they learned, and they generally recommend the program, et cetera. So that's promising as well, and as well as some positive qualitative feedback. Similar themes about nice to be in our own home to what Dr. Ozonoff mentioned, and also things about wanting more information ahead of time about what they're going to need and so on and so forth. So helpful information for us. So in terms of implications and future directions, I think this is also a common theme that has come up and may come up again, but we do see this mixture of features that may be overlapping and distinct early in development across autism and either at least early ADHD-like profiles, which can make it hard potentially to disentangle early in life kind of which path a child may be on. And so that we think speaks to the value of that cross-diagnosis approach and thinking about where can we find that overlap, and instead of thinking about it as kind of messy or the part we don't like, maybe leveraging it and thinking about how could we utilize that. And then I think just some early indications that there's potential for early screening and intervention related to ADHD, but a lot still to do to really be certain about that, including longer follow-ups. So I'd just like to thank my current team and our collaborators, many of whom are in this room, our funding sources, and also, of course, the participating families in our projects.
Happy to be here and talk about some of the work that we've been doing in this area. And I really approached this thinking about wanting to sort of reflect on some of the biggest lessons from Lonnie's work and the infant sibling approach kind of more generally, and really how that's influenced my thinking about these early identification topics and how it's influenced the things I'm working on now. So I came up with kind of 3 key takeaways that I think are really have been the most transformative in my thinking and for the field. So one is really this understanding about trajectories and variability in trajectories, and understanding, as Megan just pointed out, that there's lots of shared overlap in trajectories very early in development, and so understanding what those look like over time can help inform screening and identification practices. So I made a little schematic to really think about some of these concepts. And so you might recognize these ages across the bottom here, which are sort of the key infant sibling assessment ages. And then if we think about sort of expression of autism characteristics on a continuum, obviously this is a gross oversimplification, but just as a sort of anchoring here. So there are a couple key aspects that I just wanted to highlight as something that's really important in my work. So one is that if we think about the very earliest ages prior to 12 months, there's really not diagnostic clarity for anybody. So nobody is sort of crossing that threshold in terms of a behavioral profile where we would feel confident about making a particular diagnosis. And the other is that there's lots of overlap, even amongst different outcome groups and even different trajectories within children within that age. So there's lots of mess there, but again, as Megan just said, I think there's also a lot to be leveraged within all of that overlap. The second main thing is that if we follow children over time, there's sort of this gradual widening or differentiation amongst different trajectories. So by 18 months, there are some children where we can feel very confident about making a formal diagnosis. But if you also notice, there's a lot of other green lines there that still have not crossed that threshold. So we're still not really sure, and they're still largely overlapping with some of these other outcome groups. But as we continue following these children out until 3, those groups become much easier to differentiate. And so this really matters a lot for formal screening, because this is how we think about sensitivity and specificity. So the idea that if we look at 36 months, it's pretty easy to tell those groups apart in terms of children that we can be pretty confident will meet formal diagnostic criteria for autism, and then the children in blue that we can be pretty confident will not meet formal diagnostic criteria. So that is a really good thing for early screening, because it means that we're able to catch almost all of the children who end up in those green groups, and that we're also not unnecessarily referring children who don't meet formal diagnostic criteria. So it's a really efficient use of resources. The challenge with this is that there are a lot of children who have elevated characteristics of autism much earlier than this. And so if we wait to do formal screening until we can be really sure about everybody, then families are going to wait a really long time for that. And so we really need to balance this need for really efficacious and efficient screening practices with responding to parent concerns, particularly very early on. So we know, of course, from lots of different interviews and studies that parents have concerns often as early as the first year of life. they're noticing developmental differences. So one of the questions I'm particularly interested in is what is the significance of these early behavioral differences when we see them? So, you can imagine that there are some children who, even in the first year of life, have a behavioral profile where there are a lot of behaviors that we think are associated with autism outcomes. And so is it the case that there are some children that actually we can identify much earlier? So if we let go of the goal of trying to identify all the autism outcomes at this age, we know that we're not going to be able to pick out most of the children with autism outcomes in the first year of life. Most of them are below that threshold. But there are some children where it is pretty clear by the end of the first year of life. And so that's really what I have been focused on, is how do we respond to parent concerns? And so one of the challenges, again, that Dr. Zwagenbaum and Dr. Miller, everybody has brought up, is this need to really expand beyond infant sibling samples and out into these other cohorts. So not only infants who have particular medical histories or genetic findings, but those infants whose parents are noticing developmental differences, because those are the parents who are seeking evaluations and feedback. And this has been really challenging to do, and the reason that we have relied on the infant sibling design is because most families don't live near a university, and especially this group of infants is really just a subgroup of infants. And so it's really challenging to bring enough of them into a university center to do a prospective longitudinal study where we're asking families to come in every 3 months. So the way that we've approached that was to adapt our infant sibling battery for telehealth. And I will say that we did start doing this before the pandemic. And the way, so it really changed how we thought about it, because we were not doing it in response to the pandemic, but really trying to think about, if we want to see these infants and these families, what would we want to do? And so we sort of adapted that battery that has already been described in terms of the AOC, and instead of a Mullen, which is a standardized developmental assessment, we use a curriculum checklist, which comes from the Early Start Denver model, and can be scored on the basis of observation of naturally occurring play and routines between infants and their children, and package this whole thing for families. We send them a kit of toys, and this assessment takes about an hour. So we've done a couple of studies using this assessment now, one of which is in collaboration with Dr. Miller here, and we leveraged her ongoing prospective infant sibling study where infants who have a family history of autism, ADHD, or neither were seen in the lab with sort of the regular gold standard assessment, and then we saw them 2 weeks later using our Teddy battery. And overall, what we found is that our measures from our telehealth assessments were pretty strongly correlated with the lab-based assessments. So this, on the far left over there, are AOC scores at 6, 9, and 12 months. And then at 18 months, the lab battery switches to an ADOS, so those are pulled out separately. And then for the developmental assessment, so this is the correlation between the standardized lab-based Mullen expressive language subdomain and the verbal communication subscale on the curriculum checklist. So this is a really nice, strong correlation, and we see the same in the Mullen visual reception scale and the cognitive domain. So this is really nice to see, because it suggests that when we're doing these assessments over telehealth, we are getting a very good picture of baby's development across a variety of these developmental domains. And then in terms of the clinical utility, So what is the meaning of these early behavioral differences? We have one pilot study where we enrolled 43 babies who had these early social communication delays. 10 we saw just one time, and then the other 33 we saw longitudinally. And recently we were able to follow up with them now that they are toddlers and do another outcome visit with them. So when they were 3, when they were 2.5, we did a telehealth assessment using the TAP, and these were done by clinicians who had been uninvolved in all of the earlier infant visits, so sort of fresh eyes. And of the 30 infants that we saw, they were evenly split between meeting DSM criteria for autism, having other clinical concerns, so things like language delay, concern for ADHD, and then 10 who were typically developing. So it really suggests that these infants are really in need of services early on, that parents are picking up on developmental differences that are likely to persist. And I think, something to note, even just amongst the autism outcome group, that's 30%, which is, the same or higher than we see in infant sibling samples. Obviously, this is a very tiny pilot, so that remains to be seen how well that stays. But sort of the final point really is this slide shows the evaluations and service eligibility that these infants had at the time of their first visit. So we saw them for the first time between 6 and 12 months. They were an average age of 9 months. And splitting, looking within the group of children who had either autism or other concern outcomes, 6 out of 10 of both of those outcome groups had received an early evaluation. All of the children who had other outcomes were eligible for services, but only half of the children with autism were eligible for services. This is at 6 to 9 months. So what this is really suggesting is the behaviors that parents are picking up on are ones that are separate from the developmental domains that the birth to 3 programs are focused on. So it really suggests that this group of families is particularly underserved by the existing systems. So we're following this up by enrolling 120 babies that we're following longitudinally so that we can answer these questions a little bit better. And then we are also starting to develop interventions to support families during this period. So really focused on not trying to do diagnosis in the first year of life, but what can we do to support families who have these early developmental concerns. And then I'm also very happy that we received some pilot funding through the MINDS IDDRC to adapt our telehealth battery for Spanish-speaking families. And so we're working really hard on that and very excited to see what we find.
So I wanted to do 2 things. First, I want to talk about Dr. Zweigenbaum's work, his body of work, as it has affected me as an early intervention scientist and clinician, and how I think it's affected the field. And then I want to switch a little bit to a longer comment I wanted to make about your presentation today, which is kind of reinforced by what everybody else has talked about. I'm glad I come last, because if I go a few minutes over, I'm not making anybody else late. So I want to think about 4 areas of Dr. Zweigenbaum's work and how it has influenced early intervention science and practice. The first are the AOC papers, these methodological ways of assessing early signs and symptoms in babies. The second topic are the practice papers, which we haven't mentioned yet, but Dr. Zweigenbaum was the first author on 2 incredibly important practice papers that influenced the American Academy of Pediatrics in 2015, with a huge group of other pediatricians from across this country and Canada at least. There was a paper on screening and a paper on practice in 2015 for children 18 to 24 months at risk of autism. That's the second body of work I want to mention. The third one is the intervention work that they did with the social ABCs and some then findings that they had from this, one of the early naturalistic NDBIs, naturalistic developmental behavioral interventions for very young children with autism. And I want to end that part with a comment about the COVID paper, which Lonnie mentioned briefly, but which I want to underline a little bit more because I thought this was a watershed paper for those of us who are both involved in diagnosis and intervention. And I want to underline the moral and the values issues that he was so strongly laid out in that paper. So first of all, the AOC papers. So I'm an early interventionist, right? I've been working with little kids with autism since I was 18 years old. This is the truth of the matter. And in the science of this for almost all my adult life. And so I've been in homes working with kids, 2-year-olds, 3-year-olds with autism, while the parents are having babies, right? And so I'm in the home, I see this new baby come in the household, they're in the arm, I'm working with the toddler and the mom, and this baby is getting older and older. And we're all interested in this smiling, lovely baby, and then I'm interested in what's going on over time because I have the chance to watch this baby through the whole first year without anything other than just watching. And so one of the points that the early papers that Lonnie wrote are that these signs are subtle. When we're talking about the AOC, as if we can get these scores, they again and again in the papers underline the subtlety of these behaviors. And I was experiencing that. You can see the babies, they're not so smiley right now. What is it? Is it a reaction to me as a stranger? What is it? They're not so chatty, vocal as they were at 3 and 4 months. What is that? You see it, but you don't have words for it. You have this feeling. And what the AOC paper gave people like me was a language for talking about these subtle symptoms or signs. I'm not going to call them symptoms. It's not autism. It's not autism then. I'm going to argue a little bit about this. But it's differences. And the picture is growing. And until we had words for these and a way to measure it, there was no way of understanding how to try to support that baby's development. So what Lonnie and the team did was to give people like me a tool that gave me a language to talk with the parents about what are we seeing here, a way to quantify it. He gave us norms for thinking about where there's more risk, and then we could develop an intervention. And so we worked closely with Lonnie in about 2008 to learn this tool, and we got funding to do an infant treatment project. We actually did the first infant 6 to 12 month intervention project that was published, and it was because of Lonnie's support, both for development of the tool and for training us on the tool. We carried out an intervention that was based on some of the concepts of Early Start Denver model, but it was very much based on infant-parent interaction and infant developmental patterns in the areas that the AOC laid out. And our preliminary data, we did have a tiny control group, were positive. It was very promising intervention. And I've since treated another 30 or supported another 20 to 30 babies, mostly telehealth, because these babies are everywhere and parents everywhere find us. One of the critical elements of Megan's work is that we could never carry out this study as a full clinical trial until we could find them through telehealth and treat them through telehealth, because there are just not enough babies in any 1 or 2, 3 communities. So all of the work Megan has done and the early work we did in this, we're now hoping Megan is going to submit a clinical trial for this. And so one of the things I've learned from these babies is it's interesting. Some of them continue to show signs and symptoms and eventually end up with a diagnosis. Some of them don't, but they all develop language. It's not the language piece that it does or doesn't change things. It's more about the initiative, joint attention, symbolic, well, they all play too. Symbolic play all comes along. Those things are very responsive to intervention. whether or not the child goes on at age 3 to get a diagnosis. And their developmental scores are all much better than you would think. So anyway, thank you for the tool and for the opportunity to think about how to support these infants and their families in these first years of life. And I'm looking forward to Megan's opportunity for us to do this again. The practice papers. 2015, Lonnie led a group that said we should be screening for autism at 18 and 24 months in general pediatric practice. That was an incredible challenge to the community. We had no evidence-based interventions for 18-month-olds. We hardly had any diagnostic tools or screeners that were really able to do this work now. And with the idea of screening 18 and 24-month-olds and detecting autism risk, the whole goal is to get them into intervention, and we didn't have the interventions. And so that paper not only stimulated this huge public campaign around know the signs, what are the red flags, Autism Speaks, posters everywhere, scaring young parents to death forever, including now, which is a sad thing. But everybody's got this really on their mind now. And so Autism Speaks immediately followed that with a huge new grant opportunity and developed the Toddler Treatment Network research studies, which funded 4 to 6 low money. So they were all parent-mediator, parent-implemented interventions. I got funding for that. Susan had funding for that. I think Amy Weatherby had funding for that. Connie Kazari had funding for that. All of the EBPs that we now know, evidence-based practices for 12 to 24-month-old children, came from the funding from that Toddler Treatment Network, which was in response to the practice paper. Not only did that happen, but of course, our diagnostic tools became much better. There's a huge push to examine the sensitivity and specificity of diagnostic tools, which pushed it down to 12 to 18 months. And so that paper by itself really changed the landscape very quickly around services for young children with autism. And that was a huge public benefit from you. Thank you for that, Lonnie. The third piece of the work I want to talk about of his is the social ABC intervention. And it was one of the very first naturalistic developmental behavioral interventions to have data out there. It followed a model level of early feasibility study with pilot data, followed by a randomized controlled trial, followed by a feasibility community implementation design, and I'm sure there is now we're going to find a randomized controlled trial of the community implementation very soon. So he's really following the guidelines that we all are expected to follow as we go through these interventions. But there's one thing about this work I want to point out, and it was interesting to me, and it's something I've thought about a lot. And correct me if I'm wrong, okay? But as I read the papers, the targets were in these early, they were finding babies with the AOC like we did, and they're targeting attention, and they're targeting emotion sharing. And is there another communication? Those two I remember well. And directed vocalizations. Okay, so those three. And the idea is that when children are directing vocalizations and there's more emotional directedness with families, there's more engagement back and forth, and that will support language development. And but the targets were these changing specific behaviors with the idea, I'm sure, that there would also be changes in standardized language scores. And so in each study, they did find the changes in behavior that they were working towards. But as I read your data, thus far, they have not found effects on language development in comparison. And so this brings up a couple of interesting points, I think. One of them is the importance of knowing what your targets are and measuring those specifically. And in the last paper, I think you didn't continue to focus on language standard scores because it wasn't a useful metric in this. And I think that's an important thing. When you look at changes in certain behaviors, that's something that you can count and you see on an individual level. Changing a standard score on a standardized test, that's not a target behavior. And that represents an acceleration of a child's learning rate for language. It's a very different thing. And I think our intervention researchers, we've gotten confused about what does it mean to make progress in an intervention. And we have confused the idea of daily gains on targeted behaviors with changes in standard scores. And I think it's a big mistake to talk about children whose standard scores are below average and whose standard scores do not increase in intervention as a treatment failure. That is not a treatment failure. Treatment data should be representing what's happening on a day-to-day and week-to-week learning on your targeted objectives. Any child who is learning the objectives that are being taught, like the children were in that study, those are treatment successes. Children are learning what they are being taught. That is the measure of response to intervention, not changes in standard scores. That's a different metric, and that's about acceleration of learning patterns altogether. And I hope our field stops talking about treatment failure as changes in standard scores, because that's not what it's all about. Learning is about learning what children are needing to learn next. It's addressing strengths and supporting weaknesses. And that is where our early intervention should be focused, and that is what we should be reporting on as treatment success. And I really appreciate how that paper let the standard scores go. It wasn't important for what they were doing. I'm going to check the time. I have a little bit of time. I want to make one point on the COVID paper before I go to the final topic, because I urge every clinician in this room to read that COVID paper, because it really deals with these issues about inequitable access to care. And Lonnie challenges each of us in a very personal way, I found, to where do you stand? Is your work serving the payer who's paying you, the agency that employs you, or the system that sets the rules? Or is your work with each family serving that family and that child in their culture and in their goals? And I think about this a lot when I look at psych reports and I see 25 recommendations, and they're the same for every child. They're coming from a cut pattern. This is what we recommend in our clinic. And when you see a report that if you know the family, you know there is no way in the world that family could get one thing out of that report. It's not written for them. It's written for the ALTA. It's written for the school district. It's written for whoever. It's not written for the family. But it's the family who asked for help, and it's the family who has questions, and it's the family who's going to be getting and supporting that child and getting their needs met for the next 20 years. The family has to be our client. We have to be family-centered in our care. And so I think the challenge Lonnie threw out to me in this was, where do we stand? There are only two choices here. There's a family and there's a system. There's no middle ground. It's kind of like the environment. Are you working towards carbon reduction or are we not? And if you say we're not, it means we're working against it, because there's not a neutral position here. And I think being the advocate for the family, sometimes it means, lots of times means going to meetings with families and advocating for them. And facing IEP teams of people who are very angry at you for being in that meeting because you are there with that parent and you've helped that parent state what they want and you've supported with data why it's reasonable. But we need to do this. We need to be family-centered in our care. We shouldn't, but Lonnie talks about the destructiveness of the over-instrumentation of autism diagnosis, as opposed to clinical diagnosis. It's now the psychometric game. How many points? How many items? That's not what a developmental disorder is all about, or a disability. And that isn't what our primary role as physicians or psychologists is to do, that's a psychometrician's work. That's not the work of a diagnostician. That's why Kathy Lord always says it's not the ADOS scores, it's the clinical impressions. And we really need to hang on to that. All right, so those are some of my thoughts from his work, but I want to shift to one thing that's come up here before we end. And I love this, it's just an idea I was gathering through of all of this, and I'm looking at people, all these wonderful folks and their great brains are showing all these different trajectories, right? We see some kids moving quickly into autism, we see some kids never moving into autism, see some kids up and down. Sally Ozonoff has written a paper about the number of SIBs who are in and out of autism diagnoses across, the first 8 years of their life or something? And we're talking about this as an unstable diagnosis. But I want to think about it a different way. If we say that it's unstable or that we're late in making it, the assumption is that the autism is there from the beginning. In that brain, the autism is there, and we haven't found it yet, or our tools aren't good enough for monitoring it all the way through. And yet, if you look at their trajectories, those AOC symptoms, I would say those are not autism. Those are differences. They are developmental differences, and they occur, many of them, in many different developmental disorders. We know that autism is a result of hundreds of genes. We know that there are environmental effects. We know that there are health effects. We know that anything that affects a growing brain can increase the risk of autism. I think we should be thinking about the autism as an end point of developmental and genetic processes that are occurring through those first 24 to 36 months and that are taking form in different ways. Some of them are taking form and then they kind of correct, because that's what development wants to do. It wants to move towards typical trajectories, and some of them don't. And some of them end up having that kind of mix, but it's a little bit more ADHD and a little less autistic. For some kids, I just met a mom last week. She called me from Israel. My child is 6. He's been diagnosed with autism, speech and language disorder, motor impairment, apraxia, ADHD, and mood instability, and sensory deficit. What is it? Well, it's neurodevelopmental signs of immaturities and differences, and they all get mixed up there in autism, but now we're also calling them differently to fund people and to make clarity. It doesn't really make clarity, it makes it very confusing. But I think instead of thinking about how soon can we detect autism, to me really the issue is, where are we seeing children whose development is in need of support? And in what areas does it need support? And if we follow what the public law says we should be doing with infants and toddlers, we would be supporting their development with their families, in their home settings, and in their own environments. And they would be letting the baby's development tell us where it's going to end up. And if we continue to treat the symptoms and needs and the signs as they arise, we are doing what the child needs. We don't treat diagnoses, we treat needs and signs. The only purpose of a diagnosis is to help us know what it is we want to treat. And so I feel like all of the trajectories we've seen here, including all the interplay between ADHD and autism, really say that all of these different characteristics, language, attention, sensory functioning, motor functioning, emotional and social functioning, they're coming into a developing brain, and what's happening in that brain, both within the system and from outside the system, is affecting things on a month-by-month basis. And we need to be patient, listen to the families, support them, and not rush to a diagnosis, but really get a sense of the big picture and not try to tie this child into a specific category or send them to a specific diagnostic treatment as opposed to one that meets their needs in the most typical ecologically valid setting that exists. Because there are real downsides of getting kids into these, specialized treatments for specialized diagnoses. There's no data that supports the utility of that, no data at all. So I just want to leave you with that thought. Is autism and homunculus sitting in there somewhere in the brain, or is it the end result of many forces at work with many different points of supporting and not necessarily changing an outcome, but supporting the trajectories that this child is capable of?
My name is Evan. These are the things that are important to me. These are things that make me happy. These are things that make me, Evan. I love spending time with family. This is a bunch of family. A bunch. I love spending time with my friends at school. So, in the first picture, we were at science camp. And then in the second picture, I was with my friend Santiago. I love license plates, and I have a huge license plate in my wall.
How many?
50. I love traveling to different places, especially Florida, to visit my mom's family. So the first picture was going to Arizona, the second picture was going to England, and the last picture was going to Tennessee. I love Buddy the dog, but sometimes he makes me nervous because he barks too loud. I love Sam the cat too.
Why?
Because he's quiet. But one of my favorite things in the world is Target, and that was going to Sacramento. And no, that wasn't taken today. That was an older picture from November 2023. I go to Target almost every day, even when we are on trips. So the first picture is in Arizona, the second picture is in New York, and the last one is Massachusetts. No, I don't go to Target to buy things. I just like to look at the pictures they have, to see how they change them, to look at seasonal items, and to make pictures. Target is a place that makes me happy. I also love making videos all the time. I make videos about Target, Cookie Monster, and abandoned places. I even have my own YouTube channel, and I post videos all the time. And that was an older picture because now I completely changed my handle and my description.
And also, now you have more.
And I have even more videos and subscribers now. These are the things that make me happy, that are important to me, and that make me who I am. Thank you. My favorite color is purple.
So I know how to pick my battles, and it's really difficult to go after him. But really quickly, I'm going to talk to you about him. He's an 11-year-old boy with multiple NDDs. He is the poster child for Target. We went last week to Disney, and his favorite part of our visit to Disney was going to the Target in Anaheim. A lot of dollars later, that was his favorite part. He's also the poster child for person-centered thinking. When I was a LEN trainee, I had the opportunity of getting a certification in person-centered thinking, and that switched the way I saw him. If you notice, he talked a lot about what is important to him, what makes him happy, his preferences, his dreams, the things that he likes in life, versus what us as parents usually worry about, what is important for. Issues of health, issues of safety, services. But most importantly, for me, I'm pretty sure that all of you might have a patient that you think that person is, but for me, he's the poster child for early intervention. In every way, and I like how Sally talked about the daily gains, because all those daily gains that I have seen as a parent have added up to weekly gains, monthly gains, and yearly gains. And the child that initially he had a stroke, and that was while he started getting services. And those providers were so gracious and so also focused that they started pointing me towards there's also something else. As a parent, I thought once your child gets one diagnosis, that's all. So when they started suggesting, I struggled a little, but then he started getting services right away, aside from the services to support his stroke. What I have seen is in all those areas, social-emotional skills. He now has, that friend that he mentioned is actually a neurotypical friend from his general education class that comes and has play dates, and I see the way they act, and I don't see one pulling the other, or I don't see one doing greater things than the other. I see two children who are friends and who are the same age. Same thing with his language. The way he initiates language, his attention. I was looking at him he put his tablet away and he was paying attention for an hour. That is a great gain for me too. But also, my day job is I am an instructional coach, so I believe in coaching. For me, it has been really important when, as a parent, I have been involved, and when, as a parent, I have been given the opportunity of really knowing how things are going on and how I can also gather data and how can I also apply things. And my DEI piece, for those who know me, know that's important to me, it's I advocate for work with a lot of families who are monolingual Spanish, recent immigrants from low SES. Those parents are not going to understand or volunteer or ask for coaching. Those parents are going to see this with two lenses. One, culturally, in many countries, included mine, disability is still seen through a religious lens. What did she do? It's a good thing coming from above. And then the second thing is the power distance index, which means where I am, the way I perceive people in authority, whether it's the teacher, the doctor, the specialist. I'm not going to ask for anything. I'm not going to deny or reject anything because I might take it as I'm disrespecting you. So I just want all of you to know that. And with all the gains and everything, he's still Evan, a really wonderful child, and that's at the place he has been getting his haircut since he was 4 years old. At the beginning, it was very dramatic, and now, as soon as he gets, all the ladies are like, Evan is here, and they almost fight, and all these ladies are perfectly trained into, we're going to show him the water, we're going to show him this, we're going to preface everything to him so he feels comfortable. So thank you, everyone.
Thank you so much. I'm a mom. I'm not a clinician. So my child had signs of language delay and was without the regional at age 24 months. He is now 18. So we didn't get a diagnosis until he was 14. Actually, it was at the COVID time. So when we did, and then we got through a pediatrician, the psychiatrist, the psychologist, everybody. And then the recommendation was, he needs to go for behavioral therapy, applied behavioral therapy, ABT. Is that right? ABT? Applied behavioral therapy, which he didn't want. And then, so we did counseling. And one thing that really was a dagger to my heart is he finally said, Mom, I feel like everybody's trying to change me. So that really, Evan, thank you so much, because my name is Evan. It wasn't done for my child. And I'm guilty of that too. Everybody wanted to change him. And it was like, no wonder you're depressed.
Regardless of your child's age, I think it's never too late to validate who he is and who he is as a human being beyond any label.
I mean, I'll just add that, like, your son's story matters for a 2-year-old or a 14-year-old or a 30-year-old. That providing these kinds of supports is about enabling and empowering and sort of helping the individual develop and thrive. I thought Sally said it really well, that and it sort of speaks to how the way we're thinking has changed, that identifying these signs is not a means to an end to a diagnosis, but actually understanding the child and their needs. And your son's lucky to have you as a mom who really champions him to not be changed, but to have the opportunity to achieve his goals and dreams like any other teen. And thank you.
This one is for Evan. Where is your favorite Target ever?
My favorite Target ever is in Hillsdale Avenue, San Jose.
His
We
neighborhood
really wanted to
Target.
know, our whole table, we had to know.
One of the issues clinically I struggle with in young children is this issue of environmental influences on child development and the presenting behaviors and social affect. And in particular, I'm wondering what we understand about the role of early childhood trauma and family functioning on the development of behavioral profiles that can look like autism or ADHD, but are not, or whether we don't, and there's more work to do. Because around the same time that we're doing screening for autism in primary care, we're also starting to do screening for adverse childhood experiences. So how do we take those two results and understand the child in front of us?
I think often we can't understand the child in front of us in an hour or a visit or a week. And children change over time. I remember in our preschool having children come in who'd met all diagnostic criteria, and we were running a day treatment center at the time. In 2 weeks, we knew this child, the staff said the next day, he doesn't have autism. Children, in diagnostic situations, in strange places, in places that aren't ecologically valid, with people that they don't know, all kinds of different behaviors can come out or not come out. That's not the child in that setting. That's the child coping with a new setting. And some children have more skills than others. I think it's really the day-by-day living and what other people who know this child are telling us. And if we're focusing on what the child needs, again, the label doesn't matter. I think you're very sensitive to hold back on big, heavy labels like autism when you're not sure, and start to look at attachment relationships. Avoidant attachment, insecure attachment, it can look like social problems. Different language problems can look like difficulties that are related to autism. They may or may not be. I think it's really important to take our time, particularly with children who have more trauma, more adverse experiences, more illness, more unstable home lives. We need to take our time and really understand that child and pull in the team. We can't do it alone. What's the daycare people say? What do the teachers say? What do the parents say? It's a whole team effort to get a sense of this child. and maybe a therapist, a play therapist, or someone who has time to do that kind of work, to get to know the child. And eventually children reveal themselves. But it's a slow process. It's like with adults. Eventually we get to know people if we take the time, but we don't know them in an hour. And the more that's happened, the more complex they are. So I sound like a very sensitive doc. Your patients are lucky to have you.
Maybe I'll just add that I agree that this is such an important issue to raise. I think it takes on more importance as we try to push the boundaries of earlier identification, that we end up thinking about these autism-related issues in a more diverse population, where it may actually be very difficult to differentiate the impacts of a particular predisposition to a developmental diagnosis versus the effect of trauma. I also think it's a cautionary note as well to put too much weight on sort of non-clinical measurement tools, like sort of AI-driven ways of sort of categorizing behavior. And I think what you're raising that we really all need to keep in mind and emphasize is that context matters. And there are situations where understanding the context, the individual and the family is more important than sort of rushing to sort of a reductionistic kind of label that doesn't take account of that context.
Well, this is really more of a compliment than it is a question. I've been coming to the Mind Institute for your lecture series for many years as an early childhood educator. Sorry. Very emotional. I've seen a huge shift in seeing people from a clinical standpoint to seeing people as people first. Sally, you've always shown that, but my heart is so full. Beautiful. It's beautiful. You're going to make huge impacts in the autism community just for that reason alone.
Thank you for that.
Coming a little bit on the heels of that comment, I know this sounds like heresy, and also want to thank you all for an amazing set of talks. Sally, given what you're saying, and given our new, it seems like, focus on neurodiversity versus pigeonholing people in diagnoses, I'd just like to ask the question, where's the boundary of where we need an autism diagnosis if our goal should be to work with learning rate and to teach people to be better on all different dimensions? When do we stop needing the autism diagnosis?
I mean, I guess my perspective would be when systems change, primarily, thinking about, insurance and billing and those kinds of things. I feel like that's from my perspective, a major driver of it. And that prevents us from being able to do what you're describing and focusing more specifically on the individual domains of need rather than a diagnosis.
I agree with that, but I also think there's a real valid reason for having for wanting an autism diagnosis, and for having to not be a dirty word. I appreciate families for whom autism is always part, not when do we tell our child he has autism, but families who say, we use this word freely. It's the A word. We use it all the time. And I'm impressed by young adults and older adults who go to seek a diagnosis, even though they're successful in their lives, they're employed, they're educated, they have children, they have families. But Sally Ozonoff has a beautiful video on this of an older man. Would you share what he said? Why he explained? Okay, I remember seeing it. So this is an older man, successful in life, but depressed and lonely and feeling like something's missing. And he said until he got his diagnosis, he always thought it was what you were saying. There's something wrong with him. It was his fault that this didn't work, that he didn't have friends, this and that he couldn't get along at work. It was his fault. And he said it was the most freeing thing for him to be told, to understand that he has this condition. And this is a part of his nervous system, and that this is his wiring. This is what he has to work with. It's not his fault. It's also not the parents' fault. This is how he developed, and that it's a very important part of him. And I see this in the neurodiversity community. It's a very important part of their identities. This is who I am. And I think that's critical to have. We all seek diagnoses, right? We go get help. We want diagnoses for ourselves or our children when something's wrong. What is it? What does it mean? So I think there's absolutely utility in this. But we don't want the utility, we don't want it to work against the child or against the family, that they feel like they have to change their lives because this is what you should do for a child with autism, or change the school, or how they would raise their child because this is what you have to do for autism, or that my child can't go, we can't do these things because I have a child with autism. I think that's the interplay, is how do we help families live the lives they want to live and raise the children they want to raise with autism? How do we support that?
So a common complaint among parents of children who are eventually diagnosed or identified with a neurodevelopmental condition, including autism, is that when the parent expresses a concern about development to the child's provider, they're told something along the lines of, let's wait and see, or he's a boy and boys are slower to develop. These things are still said. Also, there are disparities in access to care and specialists and biases that can affect diagnostic impressions. I think some of those things were mentioned. So my question is, what should be done in our healthcare system now, based on what we do know so far, to ensure that more standard and empirically supported approach is taken for, and I change it now from what I had written before, a more empirically supported approach is taken for screening and support for families. I put treatment, but I changed it.
Well, I'll address one part of it, which is, in our studies with families of very young infants who have these sort of developmental concerns, we have done a lot of work interviewing them and asking them about this experience during this time period while they're sort of navigating, waiting to see what the outcome is going to be. And families are not asking for a diagnosis when they come to us. They're asking for someone to validate their observations and to support their baby's needs. So they're coming and saying, I think that my baby might be on the spectrum, but what I'm actually asking for help with is, how do I understand them from that lens? How do I help support their development? I can tell that they are, it's harder to soothe them, and so how can I help them? That's what they want. They don't want a diagnosis when their baby is 9 months old. And so I think actually some of what we should do is be more comfortable living with that ambiguity. And so if providers could say, I don't know, but I see what you're talking about, and this is what we can do to support you where you are right now, and to really come up with a plan collaboratively with families, I think can really do a lot to support them.
That was a great reply. I mean, another aspect of the question that I would just comment on is that, fundamentally it's an issue of, if it's an issue of how the medical community is operating, then it is actually an issue of initial training and sort of continuing education, and sort of how community professionals are actually linked to people who think deeply about these issues. I'm very proud because I have a master's student who just successfully defended about a week and a half ago. So his name is Nicholas. He was diagnosed with autism at the age of 6. He made his way through high school, kind of hit a brick wall in his undergraduate years in the biological sciences, shifted gears, was passionate about autism and healthcare, did a qualitative study that involved speaking to pediatric residents about what their perspectives were about what would be an optimal health care system and sort of what they needed in their own training. And those residents spoke to just the ambiguity about sort of not only sort of like that they find in the clinical context, but even sort of what they're supposed to do. Like that their supervising pediatricians weren't sure if they're supposed to be assessing and diagnosing sort of exactly what their role was. They felt like there was a sense that that autism was a bit more nuanced and complicated, but they weren't really sort of receiving sort of that support in their current training programs. But it was also a group of residents, in some part because of family connections and personal connections to autism, that actually had a lot of insight about what the needs were. So I'm both hopeful about that next generation of healthcare professionals, and I do think it really reinforces that if we really want to make a difference, we need to reach out and work with the primary care community to not just sort of teaching them screening tools, but actually sort of helping them understand those broader contextual issues and sort of what families need in terms of support. And I think we'll get there. Like, it is really promising sort of that next generation is already thinking about these issues.
I think there's one topic we haven't touched on yet that we should, and it has to do with profound autism. And I think the issue of profound autism is real, and it's a serious challenge in this day, in the current times, with the focus on neurodiversity and autism as an identity, and families who have children whom they describe as having profound autism say they have very different needs and very different experiences. And I think it ties into comments you've made around differential diagnosis. And you know, I've had families who have said to me, you know, my child was 8 years old and the school psychologist told me he had an IQ of 35 and said he had moderate to severe intellectual disability. And he's been in early intervention since he was 2, and he's been through all these medical centers. Why didn't anybody tell me? And it's clear from his IQ test and his DQ test, I'd seen them, this was clearly going to be the picture for this boy. It was clear by his 3-year-old assessment, it was clear. But it wasn't diagnosed. And I think we're not doing a service to families when we're not talking about the severity of kids' needs at the time they're asking. Like, what's the future hold? How is this going to play out? And families want to know, is this going to be severely disabled? Is he going to be one of those children that has an incredible response to intervention? What do I need to be prepared for? I think we need to be helping families understand how this may play out early on, so that they don't end up being angry at all the people that knew that child early on and didn't tell them. And so they're thinking about the resources of the family, the supports of the family, the life goals they may have had, and how those are going to start to be shaped. I think differential diagnosis is critical. Lonnie's written about this again. As soon as we can, every part of this, language, motor, cognitive, epilepsy, health problems, we need to really be making it clear to families how severely affected their child is likely to be. This is the part of the continuum you're starting to talk about. And the severe end of the continuum is going to have a very different set of needs and supports and life trajectories than are the kids that we're talking about who are developing language at 2 or 3 and have autism, but also have a lot of other skills. And the sooner we help families, don't avoid those questions. Go with them, support them. It may be that way. What would that be like for you? Help them with that, and we can't be afraid of having those dialogues with families. That's what they've come to us to find out. So I think Lonnie's emphasis on differential diagnosis across all the tests and using the diagnostic categories that we have to explain to families what is likely to come about, why are we going to AAC, all these different needs that children have and that need to be addressed early, that families need to have that picture as well.
Going back to the discussion about autism as developmental needs versus a diagnosis, so from my understanding, if someone's diagnosed with autism at age 3, as a child, they're considered to carry that diagnosis with them into adulthood, even though their developmental needs might have changed, they might have received support, or they might have grown in ways which perhaps they might not meet criteria when they're older. Do you think that an autism diagnosis should be considered as a lifelong diagnosis, or is that perhaps not the right way of thinking of it in your opinion?
I was trying to reach for the microphone earlier to the previous question too about service systems and what do we wish could change. And one of the thoughts that I had is the way, insurance payers and things it's set up is you get access at one time to a diagnostician. We just see people once. And in fact, a lot of children, especially if they don't have profound autism, you can't even sometimes tell right away if they have autism, and certainly you can't tell really what the severity is. And then coming to your question, if it isn't reevaluated, which it usually isn't, then maybe it turns into sort of by default to a lifelong diagnosis. I think that, some of the longitudinal work that's been done where people do, because it's research, study individuals over time, absolutely shows that it isn't always a lifelong diagnosis. Often it is, maybe usually it is, but not always. But we don't have the opportunity to really do that in our clinical service systems right now. And so I think, as you say, it comes back to like developmental needs and is this serving you at the moment or not, or your child, et cetera. So good point, and I don't think we know that yet.
Maybe one thing I'll add, I think we have to take an individual approach and sort of be just aware of sort of what that individual's needs are and sort of what diagnostic criteria apply. I do think that there are some potential risks where an individual is doing well with support and then sort of withdrawing the diagnosis sort of has the unintended effect of actually kind of derailing them because they're not receiving that support. I also think that even though there's good longitudinal cohort studies, I think our longitudinal research always reflects kind of practices and the ways of thinking from sort of the inception of the study, which may have been 15 or 20 years ago. So it's an interesting question now, particularly with how broad the spectrum is, sort of what is actually the life course? The truth is diagnosis is a very cross-sectional way of thinking, whereas, this diversity and developmental course. And one wonders clinically, someone who clearly meets criteria at age 3 or 4, where things have changed to the point where there's such subtlety that age 12 that they're, that they may not meet the criteria at that point. What does that individual, what can they anticipate sort of when they're 18 or 25, and would they potentially benefit sort of from some acknowledgement that of neurodivergence and perhaps some ongoing accommodation sort of when if life's challenges sort of end up sort of bringing some of those autistic features to the surface again.
I think another thing that happens is that if children do stop meeting a diagnostic criteria for autism, they very often meet it for something else. I've seen children that have come out of treatment, they end up they don't meet clinical criteria anymore for autism, but they have ADHD, they have anxiety. The neurodevelopmental basis is still there, even though the symptom profiles are changing a little bit. And you see this in the twin studies as well, the fraternal twin studies, or even the identical twin studies, as well as in the broader phenotype. So I think it's just another example of how there aren't these clean lines. We make up the separations. They're social constructs to help us in medicine and in treatment. They're not in the brain. They're all the same systems, anxiety systems, attention systems, cognitive systems, communication systems. They're involved in all these disorders. And it's kind of different balances that end up getting a diagnosis. So I think we should think neurodevelopmentally, adaptively, quality of life, and function. And know that people may need supports at different periods of time for different needs, regardless of what the particular diagnostic categories are that are checking off at this moment.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.